My disclosure are that I've received an unrestricted grant in 2012 from Covidien for a research project, and I'll show you an example of this project. Also, I've been a speaker for Covidien and CAE, and I also receive royalties from 2 textbooks I've published. And there's a third one coming up, and all the examples that you'll see today are taken from this textbook, which is on basic TE and also critical care ultrasound. I'm also supported by an endowment fund, the Richard Kaufman, and the Montreal Heart Institute. If ever you have any question or you want to send me some information, my email address is here. So I work as a general critical care physician, also cardiac anesthesiologist at the CHUM and also at the Montreal Heart Institute, but most of my practice is cardiac anesthesia and research. So my objectives are to understand the role of ultrasound in the management of brain desaturation and also to develop a systematic approach to brain desaturation. So I would tell you that before 2012, the information that we were getting from the brain at the Montreal Heart Institute and also at the CHUM was this. Okay? So this is what we had from the brain. And actually what we're doing, in fact, we're doing 2 types of monitor. We're looking at brain oximetry and also transcranial Doppler. And this is what we're doing now. So that's about it. But the true reality of the brain is way much more complex. So it's only the beginning. And we're really in the middle age of brain monitoring. Okay? So always keep that in mind. It's just the beginning. Because if you look at, for instance, some patients and you use functional magnetic resonance, you have all this heterogeneity on the brain that it's impossible for us to get in a real time for the moment. And also when you monitor, for instance, transcranial Doppler and brain oximetry, the signals might be fine and everything might be looking okay, right, but the patient might be a stroke in the posterior circulation, which we're not monitoring at all. So we've seen patients with normal brain desaturation who develop stroke postoperatively in area which were completely not monitored. So again, it's still the beginning and there's still some work to be done. So that's the algorithm that we've been developing for several years. And what you have in yellow on the algorithm are all these steps that can be modified with the information that we'll get with bedside ultrasound, either transesophageal, transthoracic, or also with a linear probe, as I will show you. Whenever you have brain desaturation in the OR and the ICU, it will be always important to look at the heart. But also it will be important to look at the vessels, the cervical vessels, the carotid. It will be important to look at the lung, and it will be important also to look at the abdomen also, because pathologies in all these areas can be associated with brain desaturation. And also, not only with transcranial Doppler, but also with 2D echocardiography, you can also see the brain. And in some patients, you have amazing windows, and I'll show you some example, where you can even see the circle of Willis. So the algorithm that, in fact, it's published in the journal that you've received on page 54 is something we've developed. It's a first draft with an internist, Dr. Elise Rodrigue, who's a fellow in critical care, and also Alexis Cournoyer, who's also an emergency doctor. And because these are some of the areas which we eventually will use brain oximetry. So the first step when you have a brain desaturation, I would say, especially if you start with a low value, just make sure it's not an artifact. And we've seen this in patients, especially who have very high frontal sinus. But this happens maybe in 1 out of 200 patients. It's very rare, but these patients are fine and they have a saturation of 22% to start with. So when you start with a low value, you have to question, is it truly a low value? But in the majority of the time, if the patient is fine, it's just an artifact. The other common situation in which we've seen low values is if you have hyperbilirubinemia, because hyperbilirubinemia will absorb infrared and then will give you very low values. So these are the 2 most common situations in which it's hard to interpret, especially a baseline value of NIRS. The second step is the desaturation unilateral or bilateral? Because if it's unilateral and happens suddenly, then you have a significant problem, and most likely it's a carotid problem, it's a vascular problem. And this is why it might be important, especially when you have aortic surgery, to take your linear probe that you use for vascular access and look at the carotid before you start. And you can even get a Doppler signal. And this is an example of a Doppler signal that you can get from an external and internal carotid artery. But just look at the carotid artery. It might be very relevant. This is a case we've reported, a patient who had an aortic dissection, and this patient had a total occlusion of the internal carotid artery. And for sure, this patient is at high risk of a stroke, especially if he has a non-functional circle of Willis. And this is an example of a patient who has an aortic dissection, and what you can see is the dissection also that goes up into the carotid artery. So this is an important findings that you can see with a linear probe. Transcorneal Doppler can also be used. In fact, there's 4 windows that can be used. This is the system that we've been using. We have the Spencer and the other system, which is used at the CHUM. But, and it's quite useful. And in fact, actually, since January, we start developing a program where we use both Transcranial Doppler and brain oximetry at the same time. And I'll just show you an example. This was the first TAVI I did about a month ago. And this was the baseline value we had. And on the system, you have you have the number of hits. So that's the number of hyperintensity signals. And you start, when we start at the beginning, we had like 121.89. And this has happened when they brought the catheter into the ascending aorta. Like you had a shower of emboli in this patient. And at the end, the count was 719 and 922 on both sides. Interestingly, what happened, in fact, yesterday night, I asked Hilary, what do you think happened with brain oximetry? And he told me exactly what happened. Nothing happened. So again, we missed all of this just with brain oximetry. But probably, if it would have been even more severe, probably then we might have seen a desaturation. The next step, if it's not unilateral and it's bilateral, and there's no evidence of systemic hypoperfusion, so the oximetry, let's say on the arm or on the legs, would be normal, then you have to think about something which is affecting venous drainage of the brain. And this is typical of a superior vena cava syndrome. And one of the things that can happen is an occlusion of your drainage. And this can be seen when you have biatrial cannulation. And this is an example of the superior vena cava, and that's the azygos vein, which is just on top of the right pulmonary artery. Sometimes what can happen is, and we see this in transplant, and we saw this also in mitral valve, is that the cannula just goes into the azygos vein and blocks all the drainage of the blood. And then you have bilateral brain desaturation, and the patient goes probably in intracranial hypertension. And with the simulator, for instance, it's possible to see the entrance of the cannula, and that's something that you can teach you. You see the entrance of the azygos vein just on top of the superior vena cava. And this is something I've learned from a gastroenterologist, because this is an area where they do biopsy. It's a common area where you can have ganglion from lung cancer or esophageal cancer. Transcranial Doppler, this is an example of the type of image you can get with a transthoracic probe, just using a cranial profile. And the Transcranial Doppler is very useful because as you develop intracranial hypertension, you can see it on the Doppler signal. What will happen is as your intracranial pressure goes up, your diastolic signal will fall, and what's called the pulsatility index will start to increase. And as the diastolic flow also, what we call the resistance index, will also increase. And up to a certain point, the flow will be reversed. And when you are in circulatory arrest, basically there's no flow. So you can see this appearing in some patients. The other elements that you can be easily accessed is look at the optic nerve. And there's a clear correlation between the size of the optic sheet and your intracranial pressure. And that's been validated with MRI, with intracranial pressure monitoring. And this is just an example of a patient who's an organ donor. And what you see here is the papilledema. So you can see this with a small linear probe. And this is an example of one of my critical care fellow who's an emergency doctor. And she was evaluating this patient who had a severe brain hemorrhage. And first what you can see is that the optic nerve sheet was 9 millimeters. The normal should be around 3 to 4 millimeters. So there was definitively a significant increase in intracranial pressure. And when the patient was admitted on the right side, there was already a reduction, significant reduction in the diastolic flow, with a pulsatility index of 1.8. And then on the next day, when in fact we declare brain death, there was now diastolic reversal. So these modalities are available to us. You just need a transthoracic probe in the operating room, and it can be learned, and it's something eventually we'll be able to master. If it's bilateral, but there's evidence of systemic involvement, like your mean arterial pressure is reduced, then you will be thinking about hypoperfusion. Just be aware that this is the relation between arterial pressure and brain oximetry is not linear. It's all over. And there's several reasons for this. Everyone may have a different level of autoregulation. But one of a very common problem that we see very often in the operating room is that the unreliability of the radial artery pressure. And this is an example of a patient. In red, you have the femoral artery pressure, and in green, in pink, you have the radial pressure. And you can see this is another example of the femoral artery pressure and the radial artery pressure when you're using dual monitor in these patients. So if we take in our experience, 1/3 of patients, elective patients, if you put both arteries, you have a significant gradient defined by a difference of 10 millimeter of mercury of mean or systolic more than 25. And this is something we've reported. This is a patient with septic shock. It's very common in the ICU also. The more the patient is on vasoactive drug, the more unreliable is the radial pressure, and this patient had a 30 millimeter difference in the mean arterial pressure. How can you do, if you have ultrasound? Well, if ever by chance you have a mitral regurgitation, then the same way you can estimate the pulmonary artery pressure, you can estimate the systemic artery pressure with the mitral regurgitation. And this is a patient who was unstable in the ICU. The radial artery pressure was 110/68. There was an MR. There was no aortic valve pathology. But the MR gave us a gradient of 165 millimeter of mercury. So when we put the femoral artery, the pressure was 180, and then we stopped, almost significantly reduced the amount of vasoactive support. And the way you can suspect this situation is you have a patient who's hypotensive, blood pressure is low, he's talking to you, and the brain saturation is normal, and he's on vasoactive drug. And you wonder, could I have a gradient? This is the classical, the typical patient in which you'll see this situation. This next step is your cardiac function. So if you have a reduced mixed venous O2, you'll have a reduction in your brain saturation. And then you might be dealing with hypoperfusion. And this is why I would say the major cause of brain desaturation is cardiac dysfunction. And that's very important because if you have brain desaturation is commonly associated with right ventricular dysfunction, but you can also have brain desaturation with left ventricular outflow tract obstruction. On one hand, you will use inotropes. But in that situation, inotropes are absolutely contraindicated. And that's the reason why sometimes people tell me, oh, that would be a nice tool to use in the ICU. My first question is that, do your critical care physician use ultrasound in the ICU? They say no. I said, no, don't use it. Okay? And that's why many people have resistance in using this monitor. Often, they don't examine the patient with ultrasound because once you see the clear correlation between your cardiac function and your brain saturation, there is no doubt in your mind that these elements, they do correlate very nicely. We also use brain right ventricular pressure waveform, which I will discuss on Friday, in order to stratify the brain desaturation. Next step, look at your end-tidal CO2. If your end-tidal CO2 is too low, there's two possibilities. Maybe you're hyperventilating. And if you're hyperventilating, you'll have a reduction of your brain saturation by hypocapnia. But you can also have low end-tidal CO2 if you have low cardiac output. And how can you make the difference? But if you get a blood gas, the gradient between the end-tidal CO2 and the arterial CO2 will be much higher if you have a reduction in your cardiac output than if it's just hyperventilation, when it will be normal. Finally, if you have systemic desaturation, you'll have brain desaturation. And that's very useful, especially when multiple problems can happen. If a patient starts desaturate, and sometimes you can lose the signal and you're not sure, is my brain desaturation secondary from hypoxemia, or is it because there's another process? Then if there's definitively a brain desaturation, or the brain saturation is normal, there's no significant hypoxemia. And ultrasound, as you will see, can be easily used to diagnose almost 95% causes of systemic desaturation. This is an algorithm that we've published. And in fact, when you look at these conditions like pneumothorax, interstitial syndrome, or pulmonary edema, pneumonia, pleural effusion, well, all these conditions can be diagnosed at the bedside with ultrasound, and these are the reported sensitivity and specificity when you compared it with CT scan. And you can also use TE to diagnose all these different conditions because they will look the same in TE as they look with transthoracic echocardiography. Finally, if the hemoglobin goes down, again, your brain saturation will go down. I'll just show you an example. This is a patient who has a baseline value of 52, 51, and then as we move on during bypass, brain saturation starts to fall, and there's no change in mean arterial pressure. There's no big difference. The only thing we noted is his hemoglobin went from 120 to 67, which is much more than what we'd expect with the degree of hemodilution. So when you have a reduction in your hemoglobin, you use ultrasound to find where is the problem. So what you do, you look in the chest cavity, and in fact what was happening, this patient had a mammary dissection and was bleeding all during the procedure in the left chest cavity, and this is what we saw. And that was the reason why the brain saturation was falling and the hemoglobin going down. The other thing that you can diagnose with ultrasound is if ever there's a clot in the stomach. This is a patient who's bleeding in the stomach. If they are bleeding in the abdomen, then you can see free fluid between the diaphragm and the liver. This is what would a hemothorax with clots would look like in the chest. So normally, when you look at the lung with ultrasound, you don't see anything. So if you see something, it's abnormal. That's why they say lung ultrasound is called making facts out of artifacts. And this is one of my colleagues who's a gastroenterologist just sent me this. So what you see here are these anechoic area in the stomach, and basically they are gastric varices. Okay, so that's another reason why someone could be bleeding. This is one of the case we had in our research project. So basically what we did, we monitored brain and somatic oximetry in 100 patients who underwent hepatic resection, and there was 10 liver transplant. And when you do this in these patients, this is the operating room setup. This is what you will see. So this was a patient who had a fulminant cirrhosis. This was his liver on March 3rd and on the 23rd. You see it completely shrink with ascites. And this is what will happen in hepatic resection. So whenever there's the clamping, and in orange you have the upper extremity, in green the lower extremity, and the upward you have the brain saturation. So whenever you clamp the IVC, you will have instantaneously a desaturation in the legs because you're having venous congestion, and then the infrared will be absorbed. So you see this, it's a universal findings. Every time you clamp the IVC, you see this. So, and then it goes back to normal. So the patients arrive in the ICU, and as he arrives in the ICU, he starts bleeding. And as you can see, he's bleeding, and all the signals are going down. The brain is going down, the upper extremity is going down, and the leg is going down. Okay? We transfuse the patient, and then what happened is that brain saturation goes up, upper extremity goes up, and then the lower extremity starts to go down. Okay? So what was happening? In fact, he was developing abdominal compartment syndrome. In fact, he was compressing the IVC from the inside. And what you do is that you use ultrasound, you confirm the bleeding, but just by monitoring the intra-abdominal pressure, the abdominal pressure was initially 13 and went up to 19. We spoke to the surgeon, we explained the situation, brought back the patient in the operating room. There was a source of bleeding, and the patient came back afterwards. And that was the evolution of the hemoglobin. So this is when the patient was bleeding, so we corrected rapidly. And because the intervention was fast, his lactate really went back to normal very rapidly. But interestingly, if you look at the mixed venous, there was absolutely no change. So we would not have detected this just by looking at the mixed venous. So in summary, reduction of NIRS are non-specific. A monitor word, the word monitor comes from the Latin monere, which means warning. So the monitor are telling us there's a problem, but they're not telling us what is the problem. The real advantage is that if you use regional NIRS, you can know that you have a regional problem. And for instance, when we have ECMO, we use it in the extremity to detect ischemia. If you have it just on the brain, that you know the problem is localized to the brain. But then if you combine brain, arm, and legs, then you can figure out where is the problem. Typically, if it's a global problem, a cardiac problem, it will be reduced everywhere. But if it's just localized to the abdomen, typically we see a difference appearing between the upper and the lower extremity. Adequate NIRS reversal depends on identification of the mechanism, and bedside ultrasound complements NIRS in order to determine more precisely the etiology of brain or somatic desaturation. Thank you for